We're good. All right, good morning and welcome to the Skilled Nursing Documentation in Service. My name is Kathy and I work for Harmony Healthcare based out of Topsfield, Mass. And I come here once a month and I take a look at the records and the documentation, provide resources. Come on in. You can have a seat and grab a packet.
Well, I figured I'd leave those front row seats for the nurses.
There's plenty of them.
Was there any more coming?
They should, but
All the rest of the unit managers.
Well, you might be on camera, but that's okay.
Oh, I'll sit back here.
And feel free to come and get a packet if you want.
Oh, yeah.
Anyways, we're Harmony Healthcare is a healthcare consulting firm based out of Topsfield, Massachusetts, and we come into the building every month. We take a look at the records and the processes, make sure you all have the tools that you need to be compliant with state and federal regulations, and also to help prepare you for all the changes that are coming down the pike in the future with regards to Medicare, managed care, skilled care, long-term care. So there's a lot that are coming on. So, as I said, I'm not going to go through every single slide in this package. This is more for your information, but we will touch on the elements of skilled nursing documentation. And your documentation is very important. Even if a patient is here for therapy, it's the nursing that drives the skill. So they could be receiving the best therapy in the world, but if your documentation doesn't support the reason why they're here for skilled stay, then you could actually have the entire claim denied. So it's very important. You know, and this is taking credit for all the work that you're doing. My background, I'm an OT. I've been an OT for over 24 years. I've pretty much worked in skilled nursing facilities and long-term care facilities, so I've worked side by side with nurses, and I know what you guys go through every day. I know what you have to put up with. So we're here to support you with any tools that you need in any way. So this is an in-service on skilled nursing documentation, and there's 4 elements, or what we call the 4 pillars of skilled nursing documentation. With all the changes ever since 1998 when PPS started, things have changed, and it seems like just when you get used to the changes, they change again. So I'm just going to cover the 4 areas that are the components of a skilled nursing note. You know, so in the PowerPoint slides here, there's information on what the skilled qualifiers are, Medicare eligibility. You know, I'll talk about some of the common documentation errors that I see that can be very easily changed because you want to make sure that you're avoiding any kind of legal or compliance issues. And there are some case studies in here as well, and we can discuss situations that you're not sure what to document on. So to qualify Medicare eligibility, the patient needs a 3-day, and that's 3 overnight qualifying stay. It needs to be in a certified Medicare bed. They need to have days available in the benefit period, or it needs to be, there's a packet right there if you want to grab them. They need to be within their 30-day benefit window, meaning that it's been within 30 days that they were last receiving skilled services. The practical matter rule, it's just not practical for this patient to get the daily skilled nursing care provided when they're at home. They either can't get a ride, it's too much of a hardship, and they need to be in a skilled nursing facility. And then there's the skilled care qualifiers. So Medicare eligibility, the patient needs to be treated for a condition which was treated during a qualified hospital stay or a condition that arose while in the SNF for a treatment of the condition for which the patient was previously at the hospital. So there's all these secondary conditions, and you know somebody could go in for a simple orthopedic procedure or a more complex fracture. The example here, a fractured hip, they develop a pneumonia secondary to immobility, and you know as nurses that if somebody is in bed and they're not getting out of bed, there are risks for skin issues, pneumonias, it just rises exponentially. And they could also have some secondary conditions that could exacerbate as well. Diabetes, we tend to see respiratory, COPD exacerbate along with the CHF. So it's connecting all of the dots. You're not just seeing them for that one particular, gone are the days, the very simple orthopedic, they come in for their knee and they're home in 7 to 10 days. Nope, they're a lot more complicated than that, especially with the increase in the cognitive disorders and dementia populations. You know that they can be very, very challenging. So the bed must be a certified bed, must have up to 100 days, and all of those areas are typically covered in the admissions process, that when this patient comes in, that they have coverage, they have days. The benefit ends after 60 consecutive days of a non-skilled level of care, and they can be a skilled level of care, but if it doesn't reflect in the documentation and in the notes, then you could actually receive a denial, because they'll look at it and say, this patient looks pretty stable, especially if somebody is documenting patient stable, patient at baseline. You want to avoid documenting. There's ways of documenting it without documenting it. But in those cases, you want to look at all of the risk factors and complications that could arise from that. So, there's some other, I'll let you go through that, the benefit period on your own, the 30-day transfer rule, the different benefit periods, the practical matter criteria that we had covered them on page 5. That's, it's a practical matter. They can only receive these services in a skilled nursing facility, because they may not be available if you have somebody who lives in a really rural area. I work in some places where they're as rural as you can possibly get, so they need to be in a SNF. Transportation's a hardship. They don't have anybody to help them. There's not enough caregiver assistance, so that type of thing. That's because it's more practical for them to be here. On page 6, it covers the leave of absence. Once upon a time, everybody thought it was kind of a hard and fast rule that if you're in a SNF, you can't go out even for a couple of hours because Medicare is not going to pay. It's not exactly set in stone. Medicare is not going to deny. But if you have a patient who's here and they're going out every day for lunch and then they're coming back after dinner, then they might reconsider that. It's like, what are you doing if you're feeling good enough to go out every day, then you might not.
What's the impact of going out overnight?
And this...
Because, I've heard you could lose your benefits.
It would be considered a skip day. It would impact your census, and you would have to actually skip that day.
But it wouldn't impact their Part A stay?
No,
okay.
It wouldn't. And what you can do in a situation like that, some patients, they can do a therapeutic leave of absence. They're ready to go home, but they're not sure, okay, is this going to work or not, with the family members. So it's kind of a test run. And it's been very successful. Either the family and the patient realizes that I'm not ready to go home, or they realize home is not a good place to be. Sometimes it can be very challenging, and they end up coming back. So yeah, you would just have to tweak the MDS and their stay days. So skilled care, page 7. I am going to kind of skip through these. It's the nature of the services. It requires the skills of a nurse. It can only be provided by the skills of a licensed nurse. I'm an OT, I'm a therapist, I can't provide those services. Has to be provided by or under the general supervision of a licensed nurse to assure the safety of the patient and to achieve the medically desired result. So it can only be provided by a nurse. So the 4 areas that we look at, there's information on RUGS intimacy, the final rule, but I'm going to jump right into it. So there's 4 levels or 4 pillars of skilled nursing documentation. The first one is the inherent complexity. This refers to services that only a nurse can provide, and it's not limited to IV feeding, IV meds, suctioning, trach care, ulcer care, tube feedings, respiratory therapy, and care for surgical wounds or open lesions, management of diabetes with injections, transfusions, chemotherapy, and early post-operative colostomy care. So a sample of documentation of a nurse's note, and this would be like the opening narrative on your note. This patient requires daily skilled nursing services secondary to, and then the inherent complexity of wound care. So you want to identify in your notes, and there should be at least one a day that identifies why the patient's there. You know, patient requires daily skilled nursing related to COPD, diabetes, amputation, colostomy care, that type of thing. What I tend to see, and I'm going to be global with this, it's not what I'm seeing here, what I tend to see in the documentation is I tend to see the notes, and after the patient's been here a while, alert and oriented ×3, no complaints of pain, call, bill, and reach, that type of thing. And sometimes it'll be several days in the notes where I'll say, what's the patient here for? So I think you know what you're doing, you know what you're doing to take care of this patient, you're taking care of the patient, but it's got to show up in the notes because you don't realize that it can be that way. Yes.
So once a day, we should take the patient's #1 diagnosis
Absolutely.
and put that in the note,
Yep.
and then go move on from there.
Yep.
Just what treatments they got, if their catheters in, all that.
Right. There should be, and really, in order to support the skilled stay, Medicare criteria, it wants, Medicare, CMS, they want documentation somewhere at least once a day that identifies that this patient is getting skilled nursing services. It could be in the narrative, sometimes I find it in the treatment, the administration record, I'll find a really nice little narrative, okay, that supports it. What could happen if it's not in there? What could happen if there's not daily documentation that supports it is that Medicare can look at it, the surveyors can look at it, well, we didn't see a daily note, so it must not have been provided, so we're not covering. They can deny you for a day, or they can deny the whole stay. But typically these patients are so complex, and we're not asking you to write a book. I know it seems like you have all these patients, but you just want to be very efficient and write smarter. And if
Should
the
we be specific about the treatment, or just that treatment was administered per orders?
If in the treatment note or the treatment, the administration, ETAR or EMAR,
Right.
if you're identifying what treatments were provided, to the skin, to anything, medication, that will support it. But if it's not in there, then it needs to be somewhere in the note. Somewhere in the note. So you want to identify that as well. And plus, it keeps it fresh in your head why this patient's here.
Right.
Especially if they were in the hospital for one reason and then another area exacerbated. I've seen some notes where they're so focused on maybe a secondary diagnosis popped up, but then they ignore the first one. So I know Faye's got some guidelines that for documentation, your chart and guidelines, perfect. That's a great tool to use and just follow that.
It's on every unit, and it is a Harmony produced book, and it's really good. It goes over every
I forgot that was
diagnosis,
down there.
every system.
Right.
People just have to
Oh,
look
yeah.
at it. It's all there.
It'll give you cues and it has most of the diagnoses. It'll give you cues. What is it that I'm looking for this patient? When, like I said, with the patients that they're getting stable. They're no longer acute. Nothing's exacerbating. Okay, they're looking pretty good. They're leveling off, but you're still providing that daily care. You want to identify the risk factors. When you think of somebody who's had a hip replacement, the biggest thing that you have to worry about is infection of that wound, of that site. So even though they're looking stable, well, they're at risk for an infection. So how am I going to assess for that? You're assessing the skin color, the temperature, pain level, patient's mental status. So you want to chart on that. You want to identify those areas. For that. So, let me see. Any other questions on that? Gather up my train of
I
thought.
think one of the things too is obviously people pay for their insurance. Well, you want to make sure they get their insurance. It would be terrible if someone doesn't get their insurance because we don't write a note, And so it's really making sure the patient's got, doesn't incur an expense that, because of us.
Right, and, and it is a business, unfortunately, we're, beholden to the government and everything. But really, what a good nursing note does, what your documentation does, it supports the work that you're doing. It really paints a clear picture of that patient. What I have seen before in other buildings in other parts of the country, I've seen the patient look very, very stable. It's like, all right, they're looking good. The insurance looks at it, and it's not just Medicare. It's other insurances as well, the managed cares, which can be very, very strict. I've seen them look at the records and say, you know what, they're looking pretty stable. I think they can go home. And I have seen people go home prematurely before they were ready, when they were still sick, when they were still unstable, and they do end up back in the hospital. So you want to tell that patient's story. I want to look at the notes and see somebody who is a sick patient kind of jump out on the page or is at risk. And the good notes, even as they start to get stable and you're talking about the risks and complications and all the secondary conditions, that wow, if they weren't here, they would be very, very sick. So we're still keeping an eye on them, making sure that they do become 100% stable, so you're supporting their reason for being here. So observation and assessment, this references conditions wherein there is a reasonable probability or possibility for complications, potential for further acute episodes, the need to identify and evaluate the need for modification of treatment, evaluation or initiation of additional medical procedures. And this is it's probably sprinkled in here. I'm just reading off of my note sheets here, so it doesn't go exactly. So don't get confused. These are the patients where, all right, they're kind of looking stable, but yet the blood sugars are a little off, the behavior's a little off. You know something might be brewing with them. There could be a UTI, could be an infection. It's an aggregate of other conditions that could be arising. They're still kind of fragile. They're still kind of vulnerable. You're observing them and you're assessing them constantly for these different medical conditions. Things are changing. Medication changes are huge, especially if it's for psychiatric medications. You want to monitor and assess for any change in condition related to the change in medications. Observation and assessment includes, but it's not limited to, fever, dehydration, septicemia, pneumonia, nutritional risk, chemotherapy, weight loss, blood sugar, impaired cognition, and mood and behavior conditions. All of those things that pop up that alerts everybody that there might be something going on. And with some of these conditions as well, they can impact coding on the MDS, which will impact the reimbursement rate, because you have a patient who is getting sick or sicker, or something's changing, they need more care, they need more eyes on them, they may need more hands-on care, and you want to reflect that as well, because they do need a higher level of resources, so you want to take credit for that as well. So it is critical, as I said before, the documentation has to occur on a daily basis, has to be every single day. And the assessments, neurological, respiratory, cardiac, circulatory, pain and sensation, nutritional, gastrointestinal, musculoskeletal, and skin assessments. These are the things that you do every day. You do every single day with every single patient. Make sure you're including it and take credit for that. So in that situation, what you can write is, this patient requires daily skilled nursing observation and assessment of signs and symptoms related to exacerbation of pneumonia. That's what you have to write. And then you can put in your vitals, lung sounds, the assessments. As long as you're identifying, this is why they're here, this is what we found. And skilled observation, it's required until the treatment regimen is essentially stabilized, when the patient's very stable. So a third component is management and evaluation of a care plan. This references the total condition and not just the care planning process. Based on the physician's orders, these services require the involvement of skilled nursing to meet the patient's medical needs, promote recovery, and ensure medical safety. You know, and it includes, what goes under here is the sum total of what seems to be unskilled services. This is everything you're doing. This patient is stable, but we're still doing all this stuff. You want to put it in there anyways. There's potential for serious complications. There's a high probability of relapse. The patient's recovery and safety. You're meeting their medical needs, and you're including the overall condition. That's where you take your nurse brain and you connect all the dots. You understand how all of these seemingly unrelated conditions can all work to prevent, you know, safe recovery of this patient. That's a unique skill set to nurses, so don't ever take that for granted, and I think most nurses do. They do take that for granted. The narratives, you can elaborate on the surgical sites, the circulatory status, status of fractures, maintenance of weight bearing, skin care, and labs. So in these situations, you can write, this patient requires daily skilled nursing for overall management and evaluation of the care plan to ensure medical safety and promote recovery due to his increasing and changing medication schedule related to immobility and decreased cognition. So that just connected all the dots. And it's just one statement in there. That identifies the level of skill, and there's the potential for changes. There's potential for this patient to still become very sick and have an exacerbation. Teaching and training is probably the fourth component, and this one I see it happening. Nurses are always teaching. The aides are always teaching. Therapy is always teaching. You know, it's all day long, and you don't realize, I never realized how much until I stood back and just observed the nurses teaching. I know it's in there probably towards the back of it. You know, somebody with new diabetic, they need insulin. Somebody with a new colostomy, somebody with a new prosthesis, catheter care, G-tube feedings, IV access sites, braces and orthotics, and wound dressings and skin treatments. Even if it's something that they won't have when they go home, they have it while they're here. They need to know what's going on, and it's very critical that you identify the teaching that's done. Teaching of the patient, teaching of other staff, teaching of the family members, especially if the family members are going to be working with this patient at home. A sample sentence or statement: this patient requires daily skilled nursing for teaching and training of self-administration of insulin injections. You know, that's a key one. You want to identify that you've trained them, and you can also identify, did the patient, how did you deliver that teaching? You know, how did the patient respond? Does the patient have difficulty comprehending? You know, that gives you an idea into their cognitive status. Are they going to be okay once they go home? Or, you know what, we've been teaching this patient all week, they still don't seem to get it. That identifies that, you know what, the rest of the team might need to get involved with this and see what we can do. Home might not be the safest place, you know, so it just alerts everybody that, you know, there could be an issue with this, you know, preventing this patient from being at home successfully. So that's the outcome that we want, is the patient to be very, very successful. So those are the four pillars of what a skilled nursing note is. And they're in here. You have different examples of observation and assessment. They're nice sentences, and they're kind of based on all of those components that are actually in that binder that Faye has. So I would definitely take the time when you have the patients that come in, especially the ones with a lot of diagnoses, and look at those cue sheets. So that will help you to, you know, be able to focus yourself. You know, there's information in here on skilled rehab. They are here for skilled rehab, but as I said, nursing drives the skill. A claim can be denied.
Terry, could you go to the day room and need a little assistance in there?
But, the claim can be denied based on the strength of the nursing notes, even if they are here for rehab. So for skilled rehab, and this is another area that can help you guys, help keep you focused in your note writing, they need rehab every day, they need to be reasonable and necessary. Therapy follows similar guidelines, has to be ordered by a physician. A therapist cannot touch a patient without a doctor's order. When they look at them. So it has to, they have to develop a treatment plan. And nursing documentation, as a therapist, I rely on that nursing documentation to help guide me in my treatment of that patient for the day. Because looking at the notes, I can identify how their night was. It looks like they might be having some blood sugar issues. It looks like their PT-INR is a little high. I might want to go and talk to the nurse about working with this patient. But also on the flip side, when therapy is done with that patient, especially if it's an orthopedic condition, therapists really, they work these patients over down in the gym. So they're going to be maybe tired, a little sore when they come up from the therapy gym. They might be in a little bit of pain, even if they've had pain meds. Therapy is going to have them on the mat, going to have them stretching out. They're going to do 150 squats with them at the parallel bar. If you ever, getting ready for the summertime, which we haven't had this year, but you go to the gym for the first time in the spring because you realize, oh my God, summertime is coming. You work yourself, you kick your own butt, and then the next morning you try and get up and out of bed and you can barely move. It's very similar for these residents. A lot of times when they go to therapy, that's the most movement that they have done in quite a while. And therapy is gentle, and of course we make sure, but they're going to come back, they're going to be sore, they're going to be tired. They might have a little bit more difficulty doing their ADLs later on in the day as they get sore. So you're also looking at their response to therapy. What I tend to see in the notes, patient working with OT and PT, cooperative, cooperative with care, pleasant, cooperative. What I'd love to see, especially in the evening time, is any documentation, patient needed increased assistance in the bathroom. And it's something just to be aware of. They might be a little more sore, their response to therapy. Because it's definitely a team. It's definitely a team effort. So there's some information here on skilled rehab, the group therapy, the final rule, Part B. The Part B, therapists see patients who are long-term care patients, and we're getting kind of towards the end, page 15. The long-term care patients, therapy works with them as well, and what we tend to see is patients who are the long-term care patients, therapy is working with them because they had a fall, they got weak, they had a decline, there was a referral, a lot of speech, a lot of mobility. What we also need to see, if there's a long-term care or a Part B patient who's on therapy, and I know that you don't need daily nursing notes, but we highly recommend documenting patient being seen by therapy for decline in mobility, decline in ADLs, to support that, because that can actually result in an audit as well. Therapy goes in there. As an OT, I'd be going down the hall, I'd have 3 aides coming up to me saying, Mrs. Jones needs 3 people to help her in the bathroom. She was a supervision for a while there, and I go in, yep, this patient definitely needs therapy, she's a lot weaker, and I work with this patient, put her on therapy, but there's nothing in the nursing documentation that identifies that it's a change in status. And that claim can actually get denied no matter what I'm putting down there. What we like to see, and once upon a time there was kind of a hard and fast rule, we need to see 3 days of documentation. Any nurses who have been doing it for a while, you might remember therapy. I need to see 3 days of documentations before I can even look at that patient. It's not a hard and fast rule, but it's a strong recommendation, because what that does, if I see 3 days where this patient was weaker, increased assistance needed and whatever, that tells me that this might not have been just a one-time deal. They were having a bad day and they weren't feeling well. This tells me that looks like it's a change in status that's about to happen, so I can pinpoint when it started happening, so that I could go in there. So your documentation also needs to support therapy. It doesn't need to be a daily note, but to support it by identifying that change. OT working with patient due to increased need in toileting related to recent UTI, recent cold, the flu, or whatever that the patient had going on. So you're connecting the dots between what you're seeing and what therapy is doing. And it supports it as well, because the insurance companies, they want to see that as well. That, boy, according to rehab, this patient's dependent now, but and they're confused and they can't follow directions, but according to what we're seeing in the nurse's notes, alert and oriented, cooperative with care, call, bail, and reach, pleasant. So you can see how there's such a discrepancy there. They're going to side with that. Well, they're looking pretty stable here, so they're going to take that piece of it. So, rehab documentation supports what you guys are doing, because we'll report nursing reports, the CNA's report, and nursing documentation can also support the therapy intervention based on what you're seeing as well. Because you also know if they're getting weaker, then they're at risk for falls. If they're more confused, there's skin issues. So you're looking for potential for an exacerbation of these once stable conditions that could be, triggering as well. So do you have any questions, any situations or anything?
I just have a question. Like, we now have PTA and COTA working to 7. And can they too write an observation note that would count, so they may know that the resident at 10 o'clock in the morning can ambulate, but they see at 7 o'clock they can barely get down the hall? Can that observation note in the nursing notes, because they can write in the nursing notes too, count as one of the confirming factors of a condition change? Because they're sort of always looking for 3 instances.
Right. And I mean, ideally, it's three of the nursing notes. I think it would be excellent to support it. I know I used to do the same thing as a therapist, because sometimes I'm walking down the hall and I observe, it could be a situation or a condition that's exacerbating right at that moment, somebody with weakness having a seizure, or I'm in the dining room and I'm looking right at this patient and they start coughing and choking. I'm going to document that, but I would also ask, when whoever does the summary at the end of the night, could you please document, because it is a change, especially if it's something that's a sudden change. And I know that nurses always do that. You chart, with the long-term care stable patients, kind of charting by exception, I guess, or by episode of anything. I would say yes.
Because we don't chart on everybody every day.
Nope, and you don't have to for the long-term care patients, but if there's a change, it's highly recommended. And usually you do. That's what I see it, and that's what will jump out at me, like, oh, looks like there was a change. And if I'm seeing that, the surveyors are seeing that as well. What would probably be a concern is if I'm seeing those notes where somebody might have forgotten, and I know you get a chart on all these people, and there's so much to keep track of, but if it's not in there and it just looks like it's just status quo for them. Same old, but yet I'm seeing therapy saying patient has, patient fell or what, there's always the falls you guys always document on. But patient needs increased assist, especially if the CNAs, if they're not coding that there's a change, you're going to have rehab saying, oh my God, there's all these changes, but yet everything else is saying there's no changes. So when I go to submit that, I'm going to be told, Miss Therapist, this doesn't look right because it doesn't gel with everything that's going on. So, the documentation just really needs to support each other and support what you're doing. And it tells the patient's story, and it helps to make sure that they're getting the care that they're, number one, that they're entitled to through their insurance, and the care that they deserve to help them get better and get back on their feet.
I'm wondering if we could, because the COTA and the PTA is new, that maybe we can get them to spend 15 minutes with you before they leave their shift, Jim, or whoever, saying, hey, I noticed this, this, and this. And then you think about it and say, okay, I'll put that in my notes today. So we might be able to take what the therapist sees and help cue the nurse on the floor what their observations are.
Sure.
So maybe we could try that too.
Right, and it's great communication, absolutely. If the therapist, some buildings don't allow therapy to write in the notes, but if they can write those contact notes, I think that's great.
Yeah. I know our therapy staff, they put, whenever there's a change, it shows up in the notes.
Yep,
And it shows up on the 24-hour report. And I check that every day.
that's excellent.
I read it and I let my staff know there's been a change too.
Yeah, that's good.
You know, because they don't always, the aides
Yeah.
don't always
Right.
check things. And sometimes I might not make it to the kiosk for whatever reason. I don't know that. I don't know there. I think we've had a couple of problems where stuff hasn't gotten onto the kiosk. Can therapy, when they input stuff into the computer, all right, like that, when they institute a change in the status of somebody's transfer status, for instance, does that automatically populate to the CNA's kiosk?
Yes, if a physical therapist makes a change in
Uh,
their
I don't touch
assistant.
their transfers.
No, I don't
Right.
either. They put all
But
that
they
in
do
there.
put
We
it
do
in.
the nursing,
They
they
put it
put
in.
all the
Yeah.
OT and
Yeah, they do
PT
that.
and
But also, you
CNA.
figure you've got 10 or 20 patients tonight.
Right.
Are you gonna read the whole kiosk every time you come in? I mean, we're supposed to do
Yeah,
that,
they're
but
supposed to.
right.
do
In a
that.
perfect world, you'd have all the time in
But
the world.
hopefully with the 24-hour report and RTMS rolling out and, you know, there's all these other ways that can help
Yeah.
summarize stuff.
Right, and it's really only when there's a change, and change could be a decline, and change could also be an improvement. I know most of the aides everywhere that, well, therapy told us they need to be an assisted too, but they really don't need to, and the patient gets mad because they're only one. That's when I encourage the aides, you need to tell your nurse, tell your therapist.
Yeah.
I don't want to tell them to go ahead and do it what the patient needs, because I know there's a system in place, but communication, it's got to come from all sides. If the aides are seeing improvement, rather than just have them continue to document that they're at that lower level, encourage them to come forward and say, hey, let me know, you know, or let therapy know, and having the evening OT and PT is a perfect opportunity for them because they work so closely together with the aides.
And maybe what we can do, because I meet with them every 3 weeks, because this is all new, is maybe, not this Wednesday, next Wednesday we can meet, and maybe one of the nurses from your shift can come down and
Sure.
say, how can we exchange information better on that shift? Because we're learning what to do with these two people. You know, it's pretty hard to hire people and say, well, we really don't know what your job is yet, but we did,
Yeah.
you know, because
And
we're
there's a
just.
learning curve.
Yeah, usually.
Great. Okay. All right,
Thank you.
thank you very much. Appreciate it.
So Kathy, we